Hey everybody, talking a little bit about how to know it's not a Morton's neuroma. And I've got a few different things in here today with our differential diagnoses list that are not necessarily not a Morton's neuroma, but can very often be there at the same time, as in they're a comorbidity or something else that's happening. Intermetatarsal bursitis is very common, particularly we say a neuroma bursal complex, because there is going to be a bit of swelling within that area, and very often when we surgically remove the nerve, we're taking a lot of that bursa with the nerve as well, because they're pretty much one of the same when we're looking surgically, although quite very different structures at the same time. We're really wanting to make sure that that plantar plate pathology is excluded or included, and making sure that we're treating it appropriately. And my typical approach is that I'll expect that it's a plantar plate pathology and a Morton's neuroma until I do my assessments and testing. And if I'm still unsure, I'm going to do an ultrasound and double check what's happening there. And plantar plate pathologies, whether they're tears or attenuations or stretching, is really going to be two different things. And some of the time we can make sure that where we're offloading those, and they're more likely going to be aching and throbbing, whereas the neuroma is going to be more of our nervy sensation, that burning, tingling, shooting type pain. And so that's going to give us a really good indicator as to which diagnosis is occurring. And if nothing else, a little bit of further palpation may isolate it. And I'm very direct. Rather than using my thumbs like I would for most areas, I'll then pull out my pinky, which is about half the size, and see if I can get a more localized area of pain to rule out the plantar plate, which you may also be doing a dorsal draw for, or whether it is actually the Morton's neuroma or neuroma bursal complex. Different other things that can happen around that area are the Freiberg's disease, or that avascular necrosis of the second, sometimes third metatarsal head. Now this is going to be quite a broad area, and a lot of the time we do find that there are effusions that come off the joint in Freiberg's disease, and so we want to be really aware of, okay, there's more likely to be pain over the top than underneath, which is typically more plantar plate or Morton's neuroma. And sometimes in mid to late stage Freiberg's disease, we're also going to find a lot of osteophytes around that dorsal aspect of the metatarsal phalangeal joint. And so that's where we can say, okay, well, it's more likely Freiberg's in this case. There's less nervy symptoms, although there still can be some. And definitely in Freiberg's is going to be a reduced range of motion in that mid to late stage as well. If nothing else, the imaging will help include or exclude what we're looking at here. When we're looking at nerve conditions, we also want to be aware of that proximal influence on our distal nerves. And for instance, as soon as I see Morton's neuroma, I'm also checking for tarsal tunnel syndrome. And that could be as simple as just doing a Tinel's test and double checking if there's any symptoms locally, or that could be pushed distally, so that we can make sure that there's not an more proximal nerve entrapment that's creating these distal nerve pain that we're finding. And potentially it could be a Morton's neuroma with tarsal tunnel syndrome. So always be on the lookout for that as well. For patients, some of them will have peripheral neuropathy, where it's diabetes mellitus associated, or it could be chemotherapy-induced peripheral neuropathy, alcohol-induced peripheral neuropathy. We need to be really aware of, okay, what's happening more broadly. There could also be some aspects of previous surgery of the back, lower back in particular, that's going to be causing some of these concerns and pains right through down to the feet that could present as a Morton's neuroma. All of these we need to be looking at, and a little bit broader questioning of our patient usually identifies whether this could be a consideration we need to be looking at. Other than that, we're looking at on x-rays that metatarsal parabola, and really making sure that there's not a metatarsalgia or relative length of the metatarsals that may be causing some of the pain that our patients are experiencing, and that overload that's occurring as well. It could be that just that metatarsal is plantar flexed that little bit much, or it's a little bit longer, and overloading this area, which may be causing the Morton's neuroma, or maybe just causing stress generally throughout that area, causing that neuroma bursal or effusions or plantar plate pathology that may be occurring. Hopefully this has given you a lot of information around how to know it's not a Morton's neuroma, as well as some of those tests and assessments that you could do. If you've liked what you've been hearing, hit the subscribe button, look at some of the other conditions, and we'll see you in the next session. Cheers.